Welcome to the new section on thyroiditis, and this is also going to be the last section on the thyroid gland disorders. Thyroiditis is one of the most ignored topics by many students because of its relative unimportance in their academic career, but its importance in the clinical career lies in the fact that it's one of the very common entities that you're going to encounter in your clinical practice. So before wasting much time, let us move on and discuss on the classification of thyroiditis. I would also like to tell one fact that I'm going to use different synonyms for a particular disease, which means in the future, if I'm going to use a synonym interchangeably, don't get confused. That's why I'm going to write in the classification system, so pay proper attention for the synonyms. So this classification I like a lot because I'm going to classify into a painless thyroiditis and a painful thyroiditis. So what are the forms of painful thyroiditis? The first is the classic dequervance thyroiditis. This dequervance thyroiditis, based on the histological picture, we also call it as a subacute granulomatous thyroiditis. Then the second form of painful thyroiditis is the infectious thyroiditis, that is called as acute bacterial thyroiditis. Generally, they form pus and abscess, so that's why it's also referred to as a suppurative thyroiditis. And the third one is the radiation-induced thyroiditis. If you recall, in the treatment of hyperthyroidism chapter, I have mentioned about radioactive iodine ablation side effect. One of the side effects is radiation thyroiditis, which is one of the very rarest form of side effects, but still significant. Happens in only 1% of the cases, but I have clearly mentioned it's one of the painful forms. If you go there and look there itself. And the fourth and the final form of painful thyroiditis is palpation or trauma-induced thyroiditis. I've seen certain cases of this palpation thyroiditis in the medical colleges, in the examination room, where many medical students tend to palpate a single thyroid gland in an urgency so that they will traumatize the thyroid gland, and that might itself result in a thyroiditis. And we have some forms of painless thyroiditis as well. Painless forms of thyroiditis, the most important is the lymphocytic thyroiditis. The general feature about this lymphocytic thyroiditis is the fact that majority of the lymphocytic thyroiditis will be autoimmune in nature, which means they will have a background anti-TPO positivity. We have two types of lymphocytic thyroiditis. One is the chronic lymphocytic thyroiditis. Second is the subacute forms of lymphocytic thyroiditis. The chronic form of lymphocytic thyroiditis is what we refer to as the classic Hashimoto's thyroiditis, which is one of the most common cause of permanent hypothyroidism in the world. Then subacute forms of lymphocytic thyroiditis, we have two different diseases. One is called a postpartum thyroiditis, and second one is the silent thyroiditis, otherwise referred to as a sporadic painless thyroiditis. So both postpartum thyroiditis and silent thyroiditis or a sporadic painless thyroiditis have a similar course, and the histology will also show a very similar picture. It's only the onset in the age group, so that's going to differentiate between them. So for example, postpartum thyroiditis is differentiated from sporadic thyroiditis by the fact that it happens in the postpartum period. That's all. Apart from that, they don't have any difference at all. And there are certain drugs that can cause thyroiditis. It's called a drug-induced thyroiditis, which I'm going to discuss at the end of the video. So what are the drugs that can cause drug-induced thyroiditis? We have drugs like interferon, alpha as well as beta, but 2-alpha specifically mentioned in a lot of literature. Then tyrosine kinase inhibitors and checkpoint inhibitors like anti-PD-1 inhibitors, anti-PD-L1 blockers, then anti-CTLA4. All these drugs also can cause thyroiditis, which have been described. But whether they exactly cause thyroiditis or not, we don't have a clear idea, but still these are data are upcoming that they can also cause thyroiditis. But most importantly, these drugs are traditional and definitely they cause thyroiditis, that is amiodarone and lithium. And there is also a lot of evidence that interleukin-2 causes thyroiditis. And the last form of painless thyroiditis is the fibrous thyroiditis, otherwise we call it as a Riddle's thyroiditis. Clear? So the radioactive iodine uptake is going to be variable in various phases of the disease. At the same time, it depends on the type of disease you are going to encounter, which we'll discuss in the classification, which you're going to see in the later part of the video. But there is something called a triphasic course, which is explained by majority of the textbooks. Usually this happens in this subacute forms of thyroiditis, which means we are going to discuss about this triphasic course only in the subacute forms of thyroiditis. You should not discuss about this triphasic course in other forms of thyroiditis, which you have to be very clear about. So what do you mean by this triphasic course in this subacute forms of thyroiditis? Usually in subacute forms of thyroiditis, not all the cases, but some of the cases classically have this triphasic course. Like you can see, initially they have this hyperthyroid phase. You should not call hyperthyroid as far as thyroiditis is concerned. We can call it as an initial thyrotoxic phase. Clear? So this is the first phase where you have high level of free thyroid hormones, but you can see very clearly that the serum TSH levels will be low. And followed by you get a hypothyroid phase. Transiently there will be euthyroid alright because they cross down and go. But the second phase is generally described as a hypothyroid phase. During the same time, you will have a high serum TSH, obviously. And the final phase is they become euthyroid, where the hormone levels will become normal and the TSH also will become normal. So which means they are going to have an initial thyrotoxic phase followed by a hypothyroid phase, and finally they will become euthyroid. Whether all the patients will become euthyroid or not, I mean, it depends on the background autoimmunity. We'll discuss about that later on. But you can see the iodine uptake, it usually correlates with the TSH. You can see if the TSH is low, iodine uptake will be low. It also rises along with the TSH. Once the TSH becomes normal, iodine uptake also becomes normal. So you can remember that iodine uptake will correlate with the TSH. So where the radioactive iodine uptake is very important. Remember, the radioactive iodine uptake is very, very important as far as thyrotoxic phase is concerned, because whenever the patient presents with thyrotoxicosis, the most important differential diagnosis is a true hyperthyroidism. For example, Graves' disease, where there is excess production of thyroid hormones in the thyroid gland. So in a true hyperthyroid state, definitely your radioactive iodine uptake will be increased. So that is one of the most important things that you have to note as far as thyroiditis, thyrotoxic phase is concerned. So whether this radioactive iodine uptake is useful during hypothyroid phase or euthyroid phase, answer is no. We are not going to use radioactive iodine uptake during the hypothyroid phase and euthyroid phase, because we are not going to determine anything, or it's not going to address any differential diagnosis or clinch a diagnosis during the hypothyroid and the euthyroid phase by using a radioactive iodine uptake. So the most important usage of this radioactive iodine uptake will come during the thyrotoxic phase of thyroiditis, where usually in the subacute forms of thyroiditis, your radioactive iodine uptake during the thyrotoxic phase will be seriously suppressed. Whereas in your true hyperthyroid states like Graves' disease, it will be definitely increased. In thyroiditis, the reason I told you why they are suppressed, because it's due to gland destruction and release of hormones. The gland is not actively producing any hormone at present. At the same time, because of the thyrotoxicosis, your TSH is low and the gland is actually normal at that point. So they respect that low TSH and they don't take up the iodine. So this is the reason for why you get a low radioactive iodine uptake in a thyrotoxic phase of a subacute thyroiditis. So how many percentage of subacute thyroiditis patient will follow this classic triphasic course? So remember, whenever you use the word classic in medicine, most of the times the incidence will be 20 to 30%. This is the usual thing that happens in medicine, which means it's rare. That's what I mean. So as far as thyroiditis is concerned, approximately around 30 to 40% of the people only with subacute thyroiditis will follow this classic triphasic course. There are certain individuals who initially start with hyperthyroid phase and they enter directly the euthyroid phase and they don't go for the hyperthyroid phase at all. I should not call hyperthyroid here because I am using the term synonymously, but as far as thyroiditis is concerned, I should use the term thyrotoxicosis only. I should not use the term hyperthyroid. But like it's a very interchangeable term, isn't it? That hyperthyroid and the thyrotoxicosis. So let us forgive the sin. And there are certain patients who don't present with thyrotoxic phase at all. They directly come with hypothyroid phase and they straight away become euthyroid and they don't have thyrotoxic phase at all. And it's not a must that all the patients should become euthyroid. There is some risk of permanent hypothyroidism also. It depends on the background autoimmunity and the persistence of anti-TPO antibodies, because anti-TPO antibodies are one of the important risk factors for developing permanent hypothyroidism. We discussed in the hypothyroidism chapter itself. So depending on how many percentage of patients will be having persistent anti-TPO, depending on that they might develop permanent hypothyroidism in the future also. So it's something like a very variable disease. But in exam, definitely you have to understand this classic triphasic course and what do you mean by that and what is the importance of the radioactive adenopathy. This is what the key point as far as the exams are concerned. So let us move on to the first type of thyroiditis, which is one of the very common entities called as Hashimoto's thyroiditis. I've given a table like this to make you understand better. Finally, I will consolidate all the tables and give it as a final table for your reference. So let us go and see the features of Hashimoto's thyroiditis. Hashimoto's thyroiditis, we know the synonym. It's also referred to as a chronic lymphocytic thyroiditis. It is characteristically painless and it's one of the most common cause of hypothyroidism in the world. Age group, it can affect any age group, but very, very common in the age group of 30 to 50 years. Obviously, it's very common in females where the male-female ratio tend to be female-male ratio tend to be approximately 9 to 10:1. Etiology-wise, definitely autoimmune. There is no doubt about that. We have clearly described in the previous videos what is the basis of this autoimmunity and what are the mechanisms, how it causes autoimmunity. We have described in detail, so we're not going to discuss in that details once again. Pathology-wise, you see features of chronic inflammation, like definitely there will be lymphocytic infiltration. Along with that, there will be germinal center formation, and these are very classical things because this germinal center formation you will not see in subacute forms. Plus, along with that, you will be seeing variable amounts of fibrosis, where in subacute forms, the degree of fibrosis again will be extremely less. Plus, more importantly, you will be seeing oncocytic metaplasia. So, which cells goes for metaplasia? These are the thyroid follicular epithelial cells that go for metaplasia and they become oncocytes. What do you mean by oncocytes? These are the cells that generally stain pink cytoplasm, that is strongly eosinophilic cytoplasm, because they contain numerous mitochondria. And in electron microscopy, it has been proven that they will have approximately 5,000 mitochondria with them, these oncocytes. These are metaplastic cells, which means they have changed their form. These are the same follicular epithelial cells. Because of the consistent inflammation and injury, they have changed their form and they have become oncocytes. These oncocytes in the thyroid gland are also called as Hürthle cells, or other name for them is Ashkenazi cells. Clear? Hürthle cells can be seen in other places, which means oncocytes can also be seen in other places like parotid gland and the kidneys also. But in the thyroid gland, oncocytes are specifically referred to as Hürthle cells or Ashkenazi cells. Clear? So you have some tumors which can arise from these Hürthle cells also, related to Hashimoto's thyroiditis. These are called as Hürthle cell adenoma and Hürthle cell carcinoma. Clear? Usually this Hürthle cell adenoma is considered as a variant of a follicular adenoma, and a Hürthle cell carcinoma is considered as a variant of a follicular thyroid cancer. Clear? At the same time, this presence of Hürthle cells is not a feature of Hashimoto's thyroiditis only. It can also be seen in patients with Graves' disease as well. But in general, patients with Graves' disease, we are not going to do a biopsy, and the diagnostic entities are completely different there. So in Hashimoto's thyroiditis, yes, we are going to do a biopsy, and that's why in Hashimoto's thyroiditis, these Hürthle cells make a lot of sense. Because in other forms of thyroiditis, when you want to compare, these Hürthle cells usually will not be seen. Only in Hashimoto's thyroiditis, among the thyroiditis causes, you will be seeing Hürthle cells. That is the reason why Hürthle cells are very, very important in Hashimoto's thyroiditis. What are the TFTs? TFTs generally they present with hypothyroid phase only. I mean, in the sense like most of the patients will be coming with hypothyroidism. Either this hypothyroidism can be subclinical or this hypothyroidism can be clinical hypothyroidism or a overt hypothyroidism. Pain? No. Definitely they'll be painless. So anti-TPO, yes, strongly positive, and they will have extremely high titers. Along with that, there will be other antibodies which can be positive, like anti-thyroglobulin positivity. At the same time, some Hashimoto's patients also may be TRAP positive, and many of these TRAPs will be blocking TRAPs only. They will never have stimulating TRAPs, which you have discussed already. ESR generally tends to be normal. It will not be elevated. But I'll tell you some variants are there. And radioactive iodine uptake is highly variable. Remember, the utility of radioactive iodine uptake is useful only when you are encountering a thyrotoxic phase. Clear? So only that time your radioactive iodine uptake is useful. Apart from that, in hypothyroid patients, your radioactive iodine uptake is not a part of your evaluation itself in the first place. Clinically speaking, there are two forms of Hashimoto's thyroiditis. One is called the goitrous form, which tends to be most common, 90%, which has association with HLA DR5. And this is the most important HLA in Hashimoto as far as exams are concerned. And many of these patients with Hashimoto will describe a smooth lump. Like that's a goiter, the anterior part of the neck. Sometimes it can be troublesome, leading to compressive symptoms also. Sometimes it can show certain nodular appearance as well, even in ultrasound. But that's not the discussion or debate right now. Second one is the atrophic form, which is much rare. It might represent the terminal stage of Hashimoto's as well, which is usually associated with the HLA DR3, which is not important here. Even though there is overlap with Graves and Hashimoto's in the HLA DR3 and B8, but in exam you have to always answer DR5 for Hashimoto. Treatment-wise, there is no role for steroids in treating Hashimoto's thyroiditis inflammation because it is usually secreted by a long-lived plasma cells, these anti-TPO antibodies, which are generally not going to be suppressed by steroids. So any immunosuppression is not usually indicated. So if the patient is in hypothyroid phase, you can treat with levothyroxine. If the patient has hypothyroidism, or if the patient has subclinical hypothyroidism, or if there is indication to treat a subclinical hypothyroidism, you can treat with levothyroxine with a standard replacement dose. That's all. But there are two important points that you have to note. Levothyroxine treatment will not reduce anti-TPO antibodies, which means anti-TPO antibodies will persist. Levothyroxine treatment is only for hypothyroidism treatment. Number two, levothyroxine treatment will decrease the goiter size because obviously they will suppress the TSH. At least the TSH mediated stimulation of the thyroid gland, which is going for goiter, will be reduced. So in patients with troublesome goiters, there are some anecdotal evidence, even though it is not mentioned in any textbooks, but there are certain clinicians as well as most of us generally tend to give levothyroxine in patients with troublesome goiter just to decrease the goiter size, even though the TFTs are normal. So this is one indication is there. This is off-label indication, but still you have to know that. But usually the indication will be hypothyroidism only, either subclinical or overt hypothyroidism. So is there any role for surgery? Yes. Surgery can be done in patients who are having big goiters and troublesome goiters or having compressive symptoms. But the utility of radioactive iodine ablation in Hashimoto's thyroiditis patients is not useful because The radioactive iodine uptake is highly variable and the thyroid gland may not take up radioactive iodine avidly. So that is the reason why surgery is better preferred in patients with troublesome coitus rather than going for a radioactive iodine ablation. There is no role for radioactive iodine ablation here. So let us see some of the pathological features of Hashimoto's. This is a classic picture, low power view of the thyroid biopsy, where you can see inflammation. That's it. So many blues, lot of blues you are seeing. All these blues are inflammation. Blue is bad. That's what we know in pathology. So these are nothing but aggregates of lymphocytes with pale germinal centers, which means you can see clearly a lot of germinal center formation, which is characteristic of Hashimoto. You can also see thyroid follicles. Majority of them are very small and atrophic. Why they are atrophic? Because of chronic inflammation. And if you put a mesostrichome, you can also see varying degrees of fibrosis in this gland, which I have not shown. And there are certain follicles in those areas. You can see prominent this bluish type of cells, more pinkish type of cells. These are nothing but oncocytic metaplasia, or otherwise called as Hurdle cells. And this is another medium to high power view of Hashimoto's thyroiditis patient, where you can see in close-up view, these are the follicles and many of them are atrophic. This you can take a normal follicle and many of them are atrophic, which are very small in size because of chronic inflammation. You can see aggregates of lymphoid follicles with germinal center formation. So these are all classic pictures, classic images that you might get in exams as far as Hashimoto's thyroiditis is concerned. There are some other points that are important to note in a Hashimoto's thyroiditis. First one is the patients are at increased risk of developing thyroid lymphoma. Even though overall risk is very rare, approximately 0.5 to 1% of the patients will get thyroid lymphoma, those who are suffering from Hashimoto's thyroiditis. Compared to the general population, the risk is actually very high, like 80 times, 60 to 80 times more risk compared to the general population. But overall risk among Hashimoto's thyroiditis patients is 0.5 to 1%. That's it. At the same time, these patients are also at increased risk of developing well-differentiated thyroid cancers. You have to very clearly understand the fact that it's well-differentiated thyroid cancers. For example, a papillary thyroid cancer. Fine. Then, what are the variable presentations? There are some variable presentations of Hashimoto's thyroiditis. Like number one is hashitoxicosis. What do you mean by hashitoxicosis? This is a very rare form of thyrotoxicosis in Hashimoto's. Usually Hashimoto's means chronic inflammation, hypothyroidism, either subclinical or overt. But rarely they can come with hashitoxicosis. Sometimes patient will be, I'll tell you the course first. Sometimes patient will be having a chronic lymphocytic inflammation in Hashimoto's thyroiditis. But this chronic inflammation might be superimposed by a sudden and acute inflammation. If there is a superimposed acute inflammation, because of gland destruction, sudden destruction of the gland and the thyroid follicles, there might be release of stored hormones, which may result in a thyrotoxicosis. And this is the mechanism of many subacute thyroiditis causing thyrotoxicosis as well. So they might result in thyrotoxicosis, where you will have an increased free thyroid hormones with a suppressed TSH. At the same time, gland also may show some pain and they may show atypical features like raised ESR as well. These are atypical features which you don't really get in Hashimoto's thyroiditis patients. These are very rare. But the most important thing is the fact that these patients, even though this thyrotoxicosis is clearly due to gland destruction, but since there is a background chronic inflammation and Hashimoto's thyroiditis going on, the radioactive iodine uptake is highly variable and it can be normal or even mildly increased. What is the importance of that? We know very well, whenever you have a thyrotoxicosis, the most important investigation is radioactive iodine uptake. Why we do that is to differentiate a subacute thyroiditis versus a Graves' disease. So whenever the radioactive iodine uptake is normal or mildly increased, it creates a considerable confusion with Graves' disease, especially when it is increased. It's very difficult to differentiate a Graves' disease from Hashimoto's hashitoxicosis in this picture. Because Graves' disease also will have increased radioactive iodine uptake, whereas Hashimoto's thyroiditis patients also may have mildly increased radioactive iodine uptake. Graves' disease patients also may have anti-TPO antibodies in approximately 70%. Hashimoto's thyroiditis patients also will have anti-TPO antibodies. TRAPS usually goes towards Graves' disease, but there are 10 to 15% of the patients who may have blocking traps in patients with Hashimoto's thyroiditis also. So it's a considerable confusion. So usual treatment of any thyrotoxicosis, with relation to thyroiditis is beta blockers. You don't generally treat with anti-thyroid drugs. But if you have any confusion, if you have a very, very confusing picture, you can transiently start with anti-thyroid drugs and you can look out for development of hypothyroidism, because in acetotoxicosis, the thyrotoxicosis is not going to be permanent at all. Whereas in Graves' disease, the thyrotoxicosis and the hyperthyroidism is going to continue and there will be recurrent hyperthyroidism. Whereas in acetotoxicosis patients, you don't expect a recurrent hyperthyroidism or a thyrotoxicosis, because the patients will settle in their acute inflammation, and once the acute inflammation settles, they'll get better and they in fact go for a hypothyroid phase once again. So that is why when you start with anti-thyroid drugs, you have to be very careful. If it's acetotoxicosis, they rapidly go to the hypothyroid phase once that acute thyrotoxic phase is gone. Clear? So, but in confusion, you can start with anti-thyroid drugs, but in general, beta blockers are more than enough if you are sure it's acetotoxicosis, but it's very difficult to be sure on acetotoxicosis. Second variable presentation, where they'll be having a thyrotoxic and hypothyroid phase that are alternating with each other. This is a very, very rare presentation. Alternate thyrotoxic and hypothyroid phase will be there. And usually, if you take this patient, they will be truly hyperthyroid, which means the radioactive iodine uptake in fact may be increased during the thyrotoxic phase. So why is the fact? Because there are certain group of Hashimoto's patients who will develop transiently stimulating traps. Stimulating traps may be transiently developed in these patients. So during that time, they will become thyrotoxic. And after some time, they will lose that stimulating traps, and once again, blocking traps will predominate and you might develop hypothyroidism. So this disease is the one that is often considered as a probable overlap with Graves' disease. We really don't know, but this is considered as a probable overlap with Graves' disease. But we have certain Hashimoto's thyroiditis patients, biopsy-prone Hashimoto's thyroiditis patients, who are developing these stimulating traps, and they may alternate between a transient hyperthyroid and hypothyroid phase. But in clinical practice, and even in theory, even in exams, stimulating traps or any traps is always equivalent to Graves' disease. Be very clear about that. Don't get confused by the fact I'm telling some variable presentation. These are atypical but rare presentations. Whenever you sit in the clinic, you always think about common presentations of a common disease. Never think about atypical presentations of a common disease in the first instant itself. Always think about traps means it's Graves' disease in clinical practice as well as exams. These are only theoretical points just to make you clear about the concepts. Number 3. So there are certain Hashimoto's thyroiditis patients. They are not really Hashimoto's thyroiditis patients, but they may not have even a thyroiditis, but they may present with something called a encephalopathy called as Hashi encephalopathy. So this is a completely variable presentation. Probably these patients may not have thyroiditis at all. Thyroiditis is there or not is not a problem here. They may not even have hypothyroidism, which means they may be completely euthyroid. So which means Hashi encephalopathy is a completely different disease. So why it is called a Hashi encephalopathy? Because many of these patients tend to have high titers of anti-TPO and probably anti-thyroglobulin antibodies, and they present with encephalopathy. That's why this was termed as Hashi encephalopathy, but they may or may not have background thyroiditis, may or may not have background hypothyroidism, and they may be completely euthyroid. So which means you should not consider this thyroiditis and thyroid function test when you are thinking about a diagnosis of Hashi encephalopathy. But the number one point I want to tell is the fact that Hashi encephalopathy is a diagnosis of exclusion. It's not a diagnosis of inclusion, it's a diagnosis of exclusion, which means patient is coming with a encephalopathy. So, and the clinical features of encephalopathy in Hashimoto's encephalopathy patients will vary very widely. It can be acute presentation, it can have fulminant presentation, it can have subacute presentation, or even some chronic presentations also have been described. For example, patient can come with an altered mental status, or dementia-like picture, maybe like a fluctuating consciousness also. They may present with seizures also. There are case reports where they present with myoclonus, but this is very important for exams. And they can come with a coma also if there is a fulminant presentation. So it is a heterogeneous presentation. The population is variable and how they present is going to be highly variable, but they present with some form of encephalopathy. And these patients, once you have ruled out all other diagnoses, including your infectious cause of encephalopathy. Now, if you see anti-TPO levels, they will be elevated. Clear? So now you can diagnose Hashimoto's encephalopathy or Hashi encephalopathy, which means patients who come with encephalopathy, when all the other diagnoses are ruled out and their anti-TPO antibodies are elevated, these patients can be considered to have Hashi encephalopathy. But the pathological or the pathogenic antibody is not considered to be anti-TPO antibodies. As far as this encephalopathy is concerned, it is considered to be an antibody called anti-alpha enolase antibody. This is consistently demonstrated in many of the Hashi encephalopathy patients, but even though it is not commercially available. This is relatively more specific for Hashi encephalopathy compared to that of other antibodies. So, but this is not commercially available as of now. Treatment, definitely steroids. That's why this Hashi encephalopathy is also referred to as something called a steroid responsive encephalopathy. We start with methylprednisolone in ICU usually, but they generally respond very well. Prognosis wise, they do very well. Prognosis, very good. If it's a fulminant, for example, patient is coming with a coma, fulminant presentation of Hashi encephalopathy, you can even use a intravenous immunoglobulin also. You can add to your regime, no problem. Fine. So what about the CSF and your EEG findings? CSF will be abnormal, incidence is 80%, 20% normal, and EEG also will be abnormal in almost 95 to 100%. In almost all patients will have abnormal EEG. CSF abnormality usually will be a mild increase in lymphocytes, mild increase in proteins, and a normal glucose. So this picture can be seen in many viral meningitis and viral encephalitis as well, and this picture can be seen in many other autoimmune encephalitis as well. So which means this is not a very specific picture for Hashimoto's encephalopathy. Again, EEG abnormality will be more of a slowing of a background rhythm, and this is again common in many of the other encephalopathies also. So they are not going to be very specific for Hashi encephalopathy. But remember again, final word is Hashi encephalopathy is a diagnosis of exclusion, not a diagnosis of inclusion. When you have ruled out all the other causes of encephalopathy, and if you see high titers of anti-TPO antibodies and the patient is in encephalopathy, diagnose a Hashi encephalopathy. So this is how you are going to make a diagnosis. These are some of the variable presentations of Hashimoto's disease or Hashimoto's thyroiditis. With this, we have completed in detail about Hashimoto's. We will go on to the next form of thyroiditis called a postpartum thyroiditis. So let us fill the chart first. Age group, usually they will affect women of childbearing age because it comes in the postpartum period. Female to male ratio doesn't make any sense because it will be happening only in females because the postpartum thyroiditis. Etiology, yes, it is autoimmune because we know that postpartum thyroiditis is a form of a subacute lymphocytic thyroiditis. Whenever I use the word lymphocytic thyroiditis, the etiology tends to be autoimmune only, and they tend to be generally painless. Pathology, you will be seeing only lymphocytic infiltrate. But compared to Hashimoto's thyroiditis, there will be paucity of germinal centers, there will be no or very mild fibrosis, and you don't see generally number of Hürthle cells as you see in Hashimoto's thyroiditis. So this is the major difference. The major feature is the lymphocytic infiltrate, but there will be no germinal center formation of fibrous or Hürthle cells, different from Hashimoto's thyroiditis. TFT wise, it's highly variable depending on the course of the disease. They may present with triphasic course, characteristically what you saw in characteristic subacute thyroiditis, or they may present with thyrotoxic phase moving to euthyroid phase directly without hypothyroidism, or they present with hypothyroid phase directly going to euthyroidism without thyrotoxic phase at all, or they might come with permanent hypothyroidism also. So the course is highly variable and the TFTs are highly variable because if I use the word this subacute thyroiditis, this is how the TFTs are going to be. Clear? Pain? No. Painless? Definitely. Antibiotitis elevated in 50 to 70% of the cases, suggesting an autoimmune etiology, and they tend to be persistent. Again, suggesting that they are clearly autoimmune. They will not be transient elevation in antibio, there will be persistent elevation in the antibio antibodies. I'll tell you why this word persistent is important when we are discussing about subacute granulomatous thyroiditis. ESR will be classically normal like Hashimoto's. Radioactive iodine uptake is not useful during hypothyroid or euthyroid phase. Radioactive iodine uptake is most useful when you have a thyrotoxic TFT, because the most important differential diagnosis for thyrotoxic TFT is Graves' disease, where it will be increased radioactive iodine uptake in Graves' disease. In this thyroiditis conditions, it will be decreased for sure. And the course of postpartum thyroiditis is highly variable, where 1/3 of the patients will follow the classic triphasic course, which means initially they present with thyrotoxic phase, which usually starts 1 to 4 months postpartum. Then they will maintain the thyrotoxic phase for a variable period of 2 to 8 weeks, during which time you don't need any treatment apart from beta blockers if they are symptomatic, because the thyrotoxic phase in a subacute thyroiditis is usually due to gland destruction, release of stored hormones. There is no active production of thyroid hormones happening in them, evidenced by the fact that there is having a very low radioactive iodine uptake. So don't give any treatment during this thyrotoxic phase except beta blockers if they are symptomatic. This applies for any subacute thyroiditis. Then they'll become hypothyroid, and this hypothyroidism may last for approximately 2 to 6 months, and finally they become euthyroid. Some patients do become permanently hypothyroid and they may not recover the thyroid function, but that's not a debate right now. So many of them will become euthyroid, obviously. Or 1/3 of the patients may come with thyrotoxicosis, but they never enter this hypothyroid phase at all. They will straight away become euthyroid after 2 to 8 weeks time. This course is seen in 1/3 of the patients. Once again, never treat this thyrotoxicosis with any antithyroid drugs or radioactive iodine ablation or surgery. Just you need beta blockers temporarily for a period of 2 to 8 weeks, that too if they are symptomatic. Another 1/3 of the patients may be presenting with hypothyroidism, where they again become euthyroid after a period of time of maybe 4 months or 6 months, and this course is seen in 1/3 of the patients. Once again, this hypothyroidism has some problem because these postpartum patients are having hypothyroidism during the postpartum period. What is the risk of having this hypothyroidism during the postpartum period? So remember, there are two problems that the women is going to face in the postpartum period because of the hypothyroidism due to postpartum thyroiditis. One is increased risk of postpartum depression or worsening of postpartum depression. So postpartum women are already prone for depression. This hypothyroidism will worsen the postpartum depression. And second thing, difficulty in weight reduction, because in the postpartum period, weight reduction is one of the keys, because whatever weight the pregnant woman has gained, they generally tend to lose in the postpartum period. But they'll feel a lot difficult in weight reduction, especially if they are facing this postpartum thyroiditis and resulting in hypothyroidism. So what will be the end result? Whatever may be the course, even though it's variable, end result is many of the women will achieve euthyroidism. Usually the incidence of euthyroidism is almost 80% at 1 year of postpartum period. So after 1 year of postpartum life, even though the women have suffered from postpartum thyroiditis, almost 80% would have achieved euthyroidism by 1 year. But remember, majority of these women has increased risk of permanent hypothyroidism in the future, which means even though it's a subacute form of lymphocytic thyroiditis, there is some evidence there could be chronic lymphocytic damage like Hashimoto's that might be going on. So that is the reason why the subacute lymphocytic forms of thyroiditis are often considered as subacute forms of Hashimoto's thyroiditis. So that's the reason why many of these women are prone to develop permanent hypothyroidism in the future because of slow destruction of thyroid gland over a long period of time, which has been proven in these patients also. So usually on follow-up, there is one study which proved like almost 50 to 80% of the women at 8 years mark, they have developed hypothyroidism, permanent hypothyroidism. Clear? This is a very important point. And second important point is the fact there is an increased risk of recurrence. There is increased risk of recurrence in subsequent pregnancies. Clear? So this increased risk of permanent hypothyroidism is very high, especially in those women who have a elevated anti-TPO. This point we have discussed multiple times in the hypothyroidism chapter itself. Whenever the patient have increased anti-TPO titers, they have a very high risk of developing permanent hypothyroidism, especially if they are persistent, still high risk of developing permanent hypothyroidism in the future. So these are some of the important points that you have to note about postpartum thyroiditis. Let us move on to the next type of thyroiditis, that is painless sporadic thyroiditis. Painless sporadic thyroiditis is also referred to as a silent thyroiditis, or it can also be called by its common pathologic name, that is subacute lymphocytic thyroiditis, which means postpartum thyroiditis as well as this sporadic thyroiditis are almost the same, except the fact that postpartum thyroiditis happen in the postpartum moment. That's all. Apart from that, there is no difference. Literally in the pathology or the course, everything will be the same. Age-wise, it's very common in the 20 to 40 years age group, but it can happen in any age group for that matters. Obviously, females will be more affected than males in the ratio of 2:1. Etiology is clearly autoimmune, characterized by lymphocytic infiltration, number one. So it's a lymphocytic thyroiditis. So pathology-wise, you will see lymphocytic infiltration. This tells you it's autoimmune. At the same time, this anti-TPO titers will be elevated, and most of the time in 60 to 80% of the patients, and many of the times it will be persistent elevation as well. Clearly again telling it is a autoimmune based disease. And again, this is considered as subacute form of your Hashimoto's thyroiditis, but even though it's not clearly proven. And difference with Hashimoto's thyroiditis, the same as what you discussed in postpartum thyroiditis, where here you will have paucity of germinal centers, fibrosis. At the same time, there will be very reduced number or no Hürthle cells in these patients. And TFT wise, once again, it's variable, because the moment I use the word subacute thyroiditis, TFTs will be variable because they can follow any different course, classic triphasic or thyrotoxic to euthyroid or hypothyroid to euthyroid or permanent hypothyroidism also. Course is highly variable. Pain, definitely no. It's a painless form of thyroiditis because it's lymphocytic. ESR classically normal. Radioactive iodine uptake scans, as of many other subacute thyroiditis, radioactive iodine uptake is most useful if the patient presents with thyrotoxic phase, where it will be reduced, gives a very good picture when you want to compare with Graves' disease, because Graves' disease patients generally will have elevated radioactive uptake, because here you will have reduced radioactive iodine uptake, which clearly differentiates it from Graves' disease. And there are some drugs probably related to this subacute sporadic thyroiditis, like amiodarone, lithium, interferons. But currently, this entity causing this kind of thyroiditis will be discussed as separately as drug-induced thyroiditis. We are not going to put under this, but still there is a terminology called drug-induced subacute lymphocytic thyroiditis, which has been currently not used by many textbooks. So these are some of the important points that you have to note about this painless sporadic thyroiditis. The next form of thyroiditis will be decoherence thyroiditis, also referred to as subacute granulomatous thyroiditis. They ask you the most important feature of this decoherence thyroiditis, it is the pain that produces. It's a very, very painful condition where the patient will come with severe thyroid pain, tender pain, or in exam clearly there will be history of neck pain. This is a characteristic feature of decoherence thyroiditis. It's very painful. Let us move on to the other features now. Age-wise, it affects a wide age group of 20 to 60 years. Females are more common than males, like 5:1 ratio. Etiology, definitely it's not autoimmune because it's granulomatous, not lymphocytic. And I'll tell you in the anti-TPO also. Etiology-wise, it is unknown. We don't know what is the exact etiology. Probably some viral etiology has been suggested. The reason is because many of these patients will have a history of URA-like illness. We don't know what is the cause. At the same time, many of these patients will present in summer, because summer is the usual peak time for getting this decurrence thyroiditis. So that is a time where enterovirus also peaks. So that is why it's thought probably this enterovirus could be a very good candidate for causing decurrence thyroiditis, but not proven at all. But there are some other viruses which have also been suggested, like Coxsackie, influenza, mumps, then echoviruses, adenoviruses. Many different viruses have been suggested, but none of them have been concretely proven. Pathologically, you won't see lymphocytic infiltrate. Instead, you will see granulomas. That's why it's called a granulomatous thyroiditis. And you will see giant cells, which usually accompany granuloma. TFTs, once again, it's highly variable. Even the majority of the patients will present with thyrotoxic phase. Most commonly, they present with thyrotoxic phase. But it's highly variable because it is a subacute form of thyroiditis. Any subacute form of thyroiditis, they will have a variable TFT. But majority of them, why they come with thyrotoxic phase? Because the first phase of thyroiditis is usually thyrotoxic phase. And these patients don't come because of thyrotoxic symptoms, they come because of pain. This pain will bring the patient much early to the hospital. That's why whenever you do a TFT, at that point they will be thyrotoxic, because they come at a very early stage itself, which will be usually a thyrotoxic phase. Obviously, you have to differentiate from Graves' disease. Two things that will differentiate. One is the pain. Graves' disease patients usually will not have any thyroid pain. Second is very much low radioactive iodine uptake, which will be less than 5% in case of a thyroiditis. It will be increased in Graves' disease. Anti-TPO may be positive, but even if positive, they will be usually transient only. They can be negative also. They are not usually positive, but even if they are positive, they usually tend to be transient and they won't persist, suggesting a non-autoimmune etiology. This is not autoimmune. So why that to a transient anti-TPO should be positive at least? Because sometimes in thyroiditis, because of gland destruction, the thyroid process is sequestered antigen. So that might release into the circulation, which might trigger antibody response. That to transiently. Later on, they will disappear because once the situation becomes normal, there will be no ongoing antibody production. ESR, this is a very important point once again. ESR will be very much raised. This also can give you a very big difference with Graves' disease and other forms of thyroiditis, where ESR will be very much increased, which is a very important feature of decurrence thyroiditis. Treatment-wise, decurrence thyroiditis, like any other subacute thyroiditis, you're going to treat, because for thyrotoxicosis, you generally don't give any treatment at all. Just treat with beta blockers. That too, if they are symptomatic. If they are hypothyroid, treat with levothyroxine. That's it. Apart from that, there is no need to treat with any special treatment. Antithyroidics are absolutely contraindicated in thyroiditis causing thyrotoxicosis. Remember, this hypothyroidism and giving levothyroxine, as far as subacute thyroiditis is concerned, you have to be very careful here also, because this hypothyroid phase also tends to be transient only. Instead, many of the patients will become euthyroid over a period of time. So, if you strongly suspect subacute thyroiditis causing hypothyroidism, you can give levothyroxine for some period of time. Later on, you can try and taper, and you can see many of the patients will do well even if you stop levothyroxine. That itself will tell you the hypothyroidism in that lady is usually due to a subacute thyroiditis. Treatment in decurrence, the thyroid function wise, you're going to treat in the same way like other subacute thyroiditis, but pain you have to take care. For the pain, you can use NSAIDs. Suppose in 1 week time, if still the pain persists and if it does not disappear, then you can use glucocorticoids like prednisolone. Clear? NSAIDs of choice usually Brufen. That's what we use. Ibuprofen, or you can use aceclofenac or diclofenac also. But very commonly textbooks will tell Brufen. These are some of the images of decurrence thyroiditis. One of our patients we received, where you can see a smooth goiter in this patient, and it was very, very painful. She didn't allow me to touch at all. This is a technetium-based scan. We didn't use because radioactive iodine scans in Chennai is not very popular right now. So we use technetium 9M per technate scan in this lady, where you can see absolutely no uptake compared to the marker. No uptake at all, less than 5%. And this is a fairly common finding in many of the subacute thyroiditis, even in Hashimoto's. This is called a cobblestone thyroid. There will be various hypoechoic areas within the thyroid gland. That's a cobblestone appearance. And that's fairly common. It's not a specific finding for D current. It can be seen in many other subacute thyroiditis as well as in Hashimoto's thyroiditis. And this histological picture for definitive confirmation, where you can see there is a huge granuloma. This is a huge granuloma that is engulfing the goiter. Along with it, you can see a giant cell here. This is a giant cell where I'm showing. We'll mark it over. This is a giant cell that you are seeing. Clear? That's a giant cell. So it's a granuloma with a giant cell, and the granuloma is engulfing the goiter. If you see in the thyroid, there is none other than it's a decurrence thyroiditis. Next type of thyroiditis is acute bacterial thyroiditis. And the age group you generally encounter this acute suppurative or bacterial thyroiditis is going to be 20 to 40 years, sexually active group, and in adults, bacterial thyroiditis risk is very high, especially if they are immunocompromised, like HIV, receiving long-term steroids. Or it can happen in children also, but this will be the exam point. If you get this acute suppurative thyroiditis, especially recurrent suppurative thyroiditis in children, you usually suspect a pyriform sinus fistula. So let me tell you some of the few points on pyriform sinus fistula. Remember, it is considered to be a remnant of fifth branchial arch that is communicating with the third and fourth branchial arch. But even though this etiology is very controversial, but is thought to be a remnant of the fifth branchial arch communicating with the third and fourth branchial arch. Usually you can suspect this pyriform sinus fistula if you have a history of recurrent bacterial thyroiditis or a suppurative thyroiditis, or if the child is suffering from a deep neck space infection like parapharyngeal abscess, retropharyngeal abscess. Fine. What is the diagnosis? Diagnosis is usually made either by two investigations. You can use endoscopy also, where you can prove the fistulous opening in the pyriform sinus. You can prove one of the fistulous opening located in the pyriform sinus. Or you can prove by barium also, where barium will show the fistulous tract to the thyroid from the pyriform sinus. So this is the image, this is the esophageal opening here, and this is the fistulous opening here. So this is the pyriform sinus, and you can see a fistulous tract here. This is the esophagus that is going down. And this is the barium swallow. In the barium swallow, you can see a fistulous tract from the pyriform sinus to the thyroid. So these images are very important for exams as well. So what is the female-male ratio? 1:1. Obviously, it's a separation, so there is no much difference between genders. Etiology-wise, infection, any infection, usually streptococcus, staphylococcus, a lot of infections are possible. Pathology, just abscess and pus, that's all you're going to aspirate. TFTs, euthyroid. Majority of the patients will be euthyroid. Other presentations are very rare. And pain, yes, they'll be painful because of the abscess. Surely they'll be painful, but it's a lot different from decurrence thyroiditis. Anti-DPO antibodies, usually negative. You don't get anti-DPO antibodies. ESR, surely elevated. Radioactive iodine uptake, remember, first of all, it is unnecessary. That's what you want to know, because radioactive iodine uptake is most important for the evaluation of thyrotoxicosis, not euthyroid patient. So it's unnecessary in the first place. Suppose if you do radioactive iodine uptake, most of the time it will be normal, even though abscess areas may be cold. Areas where you have abscess may be cold. Apart from that, if they ask you radioactive iodine uptake, it's normal only. Clear? Clinically, what is most important? The patient will have fever plus asymmetric goiter, because abscess will produce an asymmetricity. They will have an asymmetric goiter only. plus extreme pain to touch because it's under high pressure in the thyroid gland. At the same time, the patient will have normal TFT. So treatment wise, you are going to do IND, incision and drainage, plus you are going to give an antibiotic cover. That's it. So these are the important points with regards to your suppurative thyroiditis is concerned. Let us move on to the next form of thyroiditis, that is Riedel's thyroiditis. Riedel's thyroiditis is also referred to as fibrous thyroiditis, or some textbooks will infiltrating form of fibrous thyroiditis, because this fibrosis of Riedel's thyroiditis infiltrates in the surrounding area. That's one of the most important diseases, anaplastic cancer. Let us discuss in the due course. Age group affected 30 to 60 years, very commonly. Once again, it's very common in females, 3:1 ratio. Etiology wise, unknown completely. Probably an autoimmune etiology, we don't know. But why we feel it could be autoimmune is because it is associated with many other autoimmune diseases like type 1 diabetes mellitus, pernicious anemia, even Hashimoto's thyroiditis. Remember, Hashimoto's thyroiditis has an unequivocal association with autoimmune disorders, like it's associated with type 1 diabetes, pernicious anemia, even Graves' disease. That's what we call it as overlap. Addison disease, definite association with other autoimmune diseases is there for Hashimoto's. But Riedel's, maybe yes, maybe no, we don't know really. But some patients have been proven to have autoimmune associations, and some patients have association with even Hashimoto's thyroiditis. That's why, like it's mind-boggling. So it may have autoimmune association, but we don't know. Pathology, you just see dense fibrosis. Grossly, it will be a very hard gland. You cannot completely resect anyways, but because of infiltrating nature, so it will be very hard gland. So if you do a biopsy, you will see a dense fibrosis in histopathology, and you can prove that in the trichome stain as well. At the same time, they will be having one characteristic finding called a obliterative venulitis. These veins will be infiltrated with inflammation and they will be obliterated completely. TFTs, most often they will be euthyroid. Clear? But there are some 15 to 20% of the cases which can present with hypothyroidism as well. But usually they will be euthyroid. Hypothyroidism is due to fibrosis and destruction of the gland. So that's the reason. So when a critical amount of gland is destroyed, they'll go for hypothyroid phase. But generally they'll be euthyroid at presentation, most of them. But remember, the most important fact that you have to know is they can present with hypocalcemia. That's what is very important as far as Riedel's thyroiditis is concerned. Why hypocalcemia? Because this is an infiltrating disease. They can infiltrate the parathyroid gland. Infiltrate and destroy the parathyroid gland. So that is the reason why a few handful of patients may come with hypocalcemia. That's why thyroiditis with hypocalcemia, answer it's a Riedel's thyroiditis. Very important key point in exam. Pain, definitely no, it's a painless condition. Antibodies, maybe yes, maybe no. But why they are positive? Once again, due to destruction and release of the sequestered TPO antigen into the circulation, causing a transient immune response. So again, we don't know whether it's truly autoimmune or not. ESR normal. Radioactive iodine, first of all, you remember it is unnecessary. Why you want to do a radioactive iodine in a euthyroid or a hypothyroid patient? So even if you do, it will be, if done, it will be normal or decreased. That's what will happen. Clear? So the most important feature as far as Riedel's thyroiditis is concerned is his clinical features. So there are a lot of things to consider because we have to, understand a lot of things. So clinically, how they present. Number one, presentation clinically, usually they will be presenting with a very hard goiter. And many of them will have compressive or obstructive symptoms like stridor, dysphagia, because that's how it comes, because it is infiltrating into the surrounding area. And they will compress on the anterior neck structures, causing stridor, dysphagia, which is fairly common in these patients. That's how they're going to present in the first place. Obviously, I told you TFTs will be normal. Because they present with a hard lump, like in the anterior part of the neck, obviously this patient has to go for biopsy because you have innumerable DDs, because they are infiltrating and they are hard masses, thyroid masses. So you have to do a biopsy. So why you need a biopsy? Because you have so much of DDs you have with a normal TFT and a hard mass of the thyroid. The first DD is obviously anaplastic cancer. Anaplastic cancer, where you will see anaplastic cells, that spindle cells with highly pleomorphic nature is what you're going to see in the anaplastic cancer. It's also going to be infiltrating, and you have to rule out other infiltrative disorders that can come to the thyroid because they also form a differential diagnosis. Other infiltrating diseases are quite rare. You don't get at all, usually. One is amyloidosis infiltrating thyroid, usually common with systemic forms of amyloidosis like AL and AA type of amyloidosis. Even in that systemic forms of amyloidosis, thyroid involvement is quite rare. You can get with systemic sclerosis. You can get with sarcoidosis, where biopsy will once again show non-cascading granulomas, like as other areas of sarcoidosis do. And patients may have hereditary hemochromatosis with thyroid involvement, but again quite rare. There's another condition called diffuse lipomatosis. Once again, a very rare condition. Or patients may have a condition called a black thyroid. This is a very interesting condition, even though not for clinical relevance, but for it's relevant because it's interesting. Black thyroid. There have been some patients where the thyroid gland has been enlarged and it comes with, whenever they resected the thyroid gland and saw it looked, jet black. And many of these patients had history of minocycline or some other tetracycline use, even though it's very common with minocycline use. So why? Reason is unknown, because probably this minocycline could be oxidized by thyroid peroxidase in the thyroid, and why it happens in only certain patients we don't know. And minocycline is a known inhibitor of thyroid peroxidase enzyme, but a very weak inhibitor. But because of interaction with the enzyme, there is a black pigment that is produced in some patients which can accumulate in the thyroid, especially if they use minocycline for a long run, resulting in a thyroid gland like this. So this is an example of a black thyroid due to minocycline use. This is a biopsy histological picture where you can see this black pigment is accumulating in the colloid as well as in the thyroid follicular cells. This is a zoomed picture. This is a high magnification picture where you can see the black pigment accumulating in the colloid as well as in the thyroid epithelial cells as well. In the electron microscopy, the black pigment is seen usually in the lysosomes of the thyroid epithelial cell. Clear? So this is an interesting condition, black thyroid. All these things has to be ruled out. So, but usually we go for the riddle thyroiditis only. Remember, many of the patients may have associated hypocalcemia. Incidence is 10 to 15% due to infiltration of the parathyroid glands. Biopsy is what you're going to do. In biopsy, you're going to see dense fibrosis, as I already told you. Only fibrosis with obliterative venulitis. So this is an example of an obliterative venulitis, which is characteristic of Riddle's thyroiditis, where you can see this venous wall is infiltrated with inflammatory infiltrate. Along with that, the lumen is completely obliterated. This is the venous wall. And see, the intimal thickness is increased, but the luminal thickness is, luminal size is very much reduced, and you have a surrounding fibrosis as well. And this is an example of a Riddle's thyroiditis where you can see follicles. Alright, these are the follicles, but they are very small and compressed, and you can see a lot of dilated blood vessels. Again, because of compression, they become dilated, and you can see dense bands of fibrosis everywhere. So this is a characteristic feature of a Riddle's thyroiditis once again. But please understand the fact that Riddle's thyroiditis may happen as a part of, other autoimmune disorders. Other fibrosing conditions. Like, for example, you have a condition called multifocal systemic fibrosclerosis. This is a fibrosing condition of multiple areas in the body. For example, this is an idiopathic condition. We don't know why it's happening, but many different areas in the body will go for fibrosis. So example, like they can go for mediastinal fibrosis. But Riddle's thyroiditis may be one among the fibrosing conditions which is seen in this disease. They can go for retroperitoneal fibrosis. Idiopathically, if it comes, that's called Ormond's disease. You can get a Peyronie's disease, or patients may have a sclerosing cholangitis. Patients may have a inflammatory orbital pseudotumor, or they may even have a Dupuytren's contracture, which is also a fibrosing condition. And right here, Dupuytren's contracture. Clear? So this is a part of, this is a multisystemic fibrosis, but Riddle's thyroiditis can be just a part of this multisystemic fibrosing disorder. Riddle's thyroiditis mostly will come alone only, but it can be a part of this systemic disorders like multifocal systemic fibrosclerosis. Our Riddle's thyroiditis in certain patients may be a part of another generalized disease called IgG4 related disease. So IgG4 related disease is currently recognized on one of the most well-studied diseases in the recent past, like maybe in the last 10 years or so, which is well recognized in many of the patients. Previously, we thought to be a different fibrosing disease, now came under this IgG4 related disease. So again, IgG4 related disease can be diagnosed only by histopathology. You cannot diagnose by anything else, where you have a characteristic, it's also a fibrosing condition. You will see inflammatory fibrosis. Here you won't see like fibrosclerosis like what you see in multifocal systemic fibrosclerosis. Here most of them, they will have an inflammatory fibrosis. What are the characteristic biopsy findings? That's what is going to tell you the diagnosis. There's a triad of 3 findings. One is called a lymphoplasmacytoid infiltrate. Lymphoplasmacytoid infiltrate. And if you break down further, these lymphocytes will be small lymphocytes. And this plasma cells, what you see will be IgG4 secreting plasma cells. That's a very important point. Clear? And there are separate criteria to tell how much plasma cell should be there, and that should be IgG4 secreting, because you have to prove by IgG4 staining, which will be positive in these patients. IgG4 secreting plasma cells in the involved area. And these patients will have obliterative phlebitis, similar to what you have seen in the Riddle's thyroiditis, obliterative phlebitis. That's why probably, like this could be a similar spectrum of diseases with different manifestations. That's all in histology and clinical profile. And third thing, they will have a storiform fibrosis. They'll have fibrosis which will have a characteristic storiform appearance, which is nothing but a circumferential cartwheel type of appearance of fibrosis. It's called a storiform fibrosis. If you have these 3, at least 2 out of these 3, for sure you can tell it's a IgG4 related disease. Plus or minus, some patients will have elevated serum IgG4 also. This elevated serum IgG4 is not the definitive criteria, but still some of these patients, like 50 to 60% of the patients may have elevated serum IgG4. Cutoff is more than 135 milligrams per deciliter. Clear? So this is a definitive criteria for diagnosing IgG4 related disease, and this has multiple spectrums, like some patients with sclerosing cholangitis have been proven to have IgG4 related disease. Some patients with previously called as autoimmune pancreatitis, nowadays it's renamed as IgG4 related disease. So any patient with recurrent pancreatitis, you have to rule out this IgG4 related disease. So you have multiple other things that are influxing in the recent past. So you have to note that this Riddle's thyroiditis also may be a part of this IgG4 related disease, which is again a systemic inflammatory fibrosing disease. There are 2 systemic diseases which I have told you. Both are very, very important for your exams. Clear? So how will you diagnose IgG4 related disease? Let us see the histopathology images. This is an example of a storiform fibrosis. Storiform fibrosis. This is what the image you will get if at all you want to get in exams, where you can see there is concentric fibrosis with multiple cartwheel type of appearance that is radiating to all the areas. Once again, this is to show the fibrosis very clearly with trichome stain, where you can see this blue color bands which are nothing but fibrosis. Once again, you can see a cartwheel appearance of fibrosis that is radiating to multiple areas surrounding. So this is what we refer to as a storiform fibrosis. How will you treat these disorders? If it's only Riddle's thyroiditis, treatment is multiple. You have a lot of options, but none of them have been shown to be satisfactory. Steroids have been tried, methotrexate have been tried, then tamoxifen has been tried to show good results, rituximab has been tried, again to show very good results. Low dose radiotherapy, not the amount what you give for anaplastic cancer, but a low dose of radiotherapy might be helpful. Surgery is only, most of the times it is symptomatic surgeries only, conservative surgeries only. You cannot do thyroidectomy because many surgeons have tried doing thyroidectomy in radial thyroiditis and failed because you don't get the facial planes to resect the thyroid because it's infiltrating into the surroundings. You won't get the facial plane. So surgeries may be mostly conservative, like relief of obstructions. Like you can remove a part of the gland, or maybe you can just cut the isthmus and remove, so that at least thyroid goes in the side and your anterior neck structures will be relieved from compressive symptoms. So these are the treatment options available for true radial thyroiditis. In multifocal systemic fibrosclerosis, very rare entity. I don't think many of you will even encounter in their life. So if at all you encounter, you are going to treat with IV methylprednisolone, pulse plus other immunosuppressive agents. This is the thing that we generally give. For IgG4 related disease, they generally respond well to steroids. You can try rituximab also in this condition because it's nothing but plasma cells. These lymphocytes and plasma cells that are the problem here. So you can stop them by giving rituximab. It's an anti-B cell drug, isn't it? So steroids are also very good in this disease. So this is how you treat IgG4 related disease. There are a lot of things to note in radial thyroiditis. I think this must have been helped you a lot. Let us move on to the summary now. So of all what I've discussed till now, I've put it in a summary and a table form for you. So from the age group to sex to pathological findings to thyroid function to 24-hour radioactive iodine uptake. So remember, this 24-hour radioactive iodine uptake is useful only if the patient is presenting in thyrotoxic phase. Otherwise, it's not useful. And in all these subacute thyroiditis, remember, all these three things are subacute thyroiditis, right? You have to be very clear in subacute thyroiditis. The treatment is very, very conservative. If they present with thyrotoxic phase, we are just going to treat it symptomatically, only with beta blockers, if at all if they have symptoms. If they present with hypothyroid phase, you can treat with levothyroxine. That too only temporarily, but you have to keep monitoring the TFTs. At one point of time, you can taper and wean the levothyroxine because many of these patients might recover from the hypothyroidism eventually. So you have to be careful about unnecessary long-term levothyroxine as well. So remaining everything we can understand in this table. You can have a look at it later on, and painful means it's only these two, the suppurative thyroiditis and decoherence thyroiditis. So these are the two things that are going to be very, very painful in it. So in exam, usually whenever they get thyroid pain, it usually means a decoherence thyroiditis unless proved otherwise. Clear? In exam, if they tell thyroid pain, if the examiner is very generous, will give history of URI also. Plus, if the patient presents with thyrotoxicosis, you need not see any other thing. You can straight away answer decoherence thyroiditis. So is there any other conditions that will produce painful thyroiditis? So remember, you have to also remember radiation thyroiditis, which can be painful. There's another entity called palpation thyroiditis, which also will be painful, but usually in exam they won't be asking you this. Remember, in decoherence thyroiditis also you have a low radioactive iodine uptake, whereas in radiation as well as palpation thyroiditis also you'll have a low radioactive iodine uptake. But in exam, always go for decoherence thyroiditis if they present with thyrotoxicosis. But radiation and palpation thyroiditis are generally going to present with euthyroid picture or a hypothyroid picture only. Thyrotoxicosis is generally quite rare. Thyrotoxicosis, thyroid pain, decoherence, definite evidence is low radioactive iodine uptake. Radiation thyroiditis and palpation-induced thyroiditis or traumatic thyroiditis also will come with thyroid pain, and they will also have a low radioactive iodine uptake only. So clear, this is a summary. You can go and revise this later on. You can pause for a second and see what is happening. Let us move on to the final topic, that is drug-induced thyroiditis. What are the drugs that can induce thyroiditis? There are a lot of drugs which induce thyroiditis by various mechanisms. First one is direct cytotoxicity, like your amiodarone, lithium, and minocycline. All these things can induce cytotoxicity. Because of that, they can induce thyroiditis and even hypothyroidism. All these drugs are, whatever I'm going to tell, are prone to produce hypothyroidism as well. Remember, in this amiodarone, we are going to discuss separately in some time in detail as a tabular form. But lithium, I'll have a special mention here because lithium is known to increase anti-TPO titers. People who are negative for anti-TPO before starting lithium, after starting lithium, they might become positive for anti-TPO, which means it produces some form of autoimmunity. We don't know how. And people who are already having anti-TPO titers will have increased anti-TPO titers after starting with lithium. So which means if they already are anti-TPO positive, lithium treatment will increase the risk of developing permanent hypothyroidism. Clear? You have to be very clear about that. And they can cause thyroiditis also. I told you, apart from imparting the autoimmunity, they can cause thyroiditis as well. And it also can inhibit sodium iodide symporter. All these are very important points that have been asked in exams. Lithium can inhibit the sodium iodide symporter. There are certain drugs that produce thyroiditis and hypothyroidism by immune dysregulation. What are they? Lithium, yes, I told you they can induce autoimmunity and they can cause immune dysregulation. And using TKs, tyrosine kinase inhibitors, and interferon alpha or interferon beta, interleukin 2, all these drugs. Then anti-TNF drugs and your checkpoint inhibitors, anti-PD1, anti-PDL1, and anti-CTLA4 drugs like ipilimumab. All these can impart immune dysregulation and they may cause thyroiditis as well as hypothyroidism. All these things we have discussed in the hypothyroidism chapter itself. And due to ischemia, certain drugs can induce hypothyroidism and thyroiditis. For example, a tyrosine kinase inhibitor, because tyrosine kinase inhibitors also inhibit various tyrosine kinases like VEGF receptor, which is a very important thing in producing a vascular supply to a particular area. So these are the drugs that induce thyroiditis in general. But for exam's sake, the lithium and amiodarone are the most important. Clear? Others we have discussed, because this anti-PDL1 may be asked in institute exams, with my knowledge, but this amiodarone lithium is important for any exam. Lithium we have already completed. Amiodarone we have not yet completed. So let us go on and see what is the amiodarone related thyroid disease. First of all, why the name amiodarone came? Because amiodarone contains a lot of iodine. That's the reason amiodarone. I am containing iodine, a lot of iodine. So by its molecular weight, it's 37% of the weight is made of iodine. Clear? This iodine creates the drug's efficacy also as a broad spectrum antiarrhythmic, but still one of the very commonly used antiarrhythmic, but it has its own side effects, especially on the thyroid. So amiodarone can produce hypothyroidism as well as it can produce thyrotoxicosis. There are two types of thyrotoxicosis induced by amiodarone. One is called amiodarone-induced thyrotoxicosis type 1 and amiodarone-induced thyrotoxicosis type 2. These are two types of thyrotoxicosis amiodarone is going to produce. At the same time, it can produce hypothyroidism as well. So what are the differential features? Remember, usually the mechanism behind amiodarone-induced thyrotoxicosis type 1 is excessive iodine. So usually this excessive iodine, I told you, if you have a history of pre-existing thyroid disease, if you have a history of pre-existing thyroid disease, like for example, a multinodular goiter or a Graves' disease, there might be a defective autoregulation. I told you whenever you have a pre-existing thyroid disease, this is the first chapter of thyroid I told you in anatomy and physiology, where I have clearly mentioned that if we are going to have some pre-existing thyroid disease, this excessive iodine might result in defective autoregulation, which means they might not go for a blockade. Instead, this excessive iodine may result in overproduction of the thyroid hormones. So obviously, this excessive iodine in patients with history of pre-existing thyroid disease may produce hyperthyroidism by Jod-Basedow effect because of defective autoregulation. You have studied it. So that is the mechanism here, defective autoregulation. That is also the reason why this amiodarone-induced thyrotoxicosis type 1 is very common in iodine deficient areas, because in iodine deficient areas only you will encounter a multinodular goiter very commonly. So that's the reason. Amiodarone-induced thyrotoxicosis type 2, what is the mechanism? It's thyroiditis. That's all. And this thyroiditis is very different from subacute thyroiditis. It is not subacute, it's not acute, it's not chronic, but a different form of thyroiditis. It should not be compared with your routine subacute form of thyroiditis in the first place. What about hypothyroidism? Hypothyroidism again is due to excess iodine, but here once again many patients will have history of pre-existing thyroid disease. But here they will not be having this multinodular goiter or Graves' disease. Instead, many of the patients may have history of some autoimmune thyroid disease. Autoimmune thyroid disease like Hashimoto's or subacute lymphocytic thyroiditis, and many of the patients will be anti-TPO positive. They might have anti-TPO positivity. Clear? So because of that, once again, there might be defective autoregulation. I told you there is another form of defective autoregulation where the patients will have a Wolff-Chaikoff block, but they may not recover. Usually a normal thyroid gland, after excess iodine load, even though they get a Wolff-Chaikoff effect, if you continuously give iodine, over time they will recover. That's called a Wolff-Chaikoff escape. But if there is a defective autoregulation due to pre-existing thyroid disease, they may not recover from the block and they'll have a prolonged Wolff-Chaikoff block. So that's the reason why they go for hypothyroidism. But remember, this amyloidosis hypothyroidism usually is very common in iodine sufficient areas, because these autoimmune thyroid diseases are very common in iodine sufficient areas rather than deficient areas. But even though we are classified based on the mechanisms, iodine deficient, iodine sufficient areas, but anything can happen in any patient, so you have to be very clear about that. What about the antibodies? Antibodies, are they positive? Like they may be positive in AAT type 1. Usually positive antibodies will be TRAPS or anti-TPO. Because I told you in MNG, 15% of the patients, elderly patients may have this anti-TPO positivity, and Graves patients will definitely have TRAP positivity. So some antibody may be positive. I'm not telling always. Usually in amyloidosis thyrotoxic type 2, there won't be any antibodies. Here usually they'll be positive, they'll be anti-TPO positive. That's the reason why they develop hypothyroidism. That is the reason I told you in the hypothyroidism chapter itself, presence of anti-TPO indicates if you start with amiodarone in those patients with positive anti-TPO, there is a risk of permanent hypothyroidism. Go back to your hypothyroidism chapter and see, I would have clearly mentioned there. So what will be the TFT? TFT will be thyrotoxic, obviously here, there is no doubt. Here also it will be thyrotoxic as the name suggests. Here there will be hypothyroid. What will be the radioactive iodine uptake? Remember, radioactive iodine uptake here will be normal or even increased radioactive iodine uptake. Where there will be normal, where there will be increased. Usually radioactive iodine uptake is increased. That's the commonest picture here. Usually happens in iodine deficient areas. That is because of Jod-based effect, they'll have increased radioactive iodine uptake. This normal radioactive iodine uptake can be seen in if patient develops this amyloidosis thyrotoxic type 1, even though, like theoretically speaking, I gave all the mechanisms. It's not like it's a black or white. It's not like you will get this AAT type 1 only in iodine deficient areas. You can get anything in any area. So just for theoretical sake and most common sake, I have told that. But they can be seen in iodine sufficient areas also. If you see in iodine sufficient areas, the radioactive iodine uptake can be normal. But in exam, you have to answer this only. That radioactive iodine uptake in type 1 is increased because of the increased iodine intake through Jod-based effect in amyloidosis thyrotoxicosis type 1. In AAT type 2, usually they will have a suppressed radioactive iodine uptake. That is because of the thyroiditis. Clear? Obviously, thyroiditis, you will have a suppressed radioactive iodine uptake only. What about hypothyroidism? In hypothyroidism is highly variable. First of all, you don't need radioactive iodine uptake scan is unnecessary. You don't need this in fact in the first place in a patient who's suffering from hypothyroidism. But even if you do, it will be highly variable, but it will be decreased in iodine sufficient areas. Iodine sufficient areas, it might be decreased. But you don't need generally, it's highly variable. Don't need to confuse yourself by doing radioactive iodine uptake in a hypothyroid patient. Then vascularity in Doppler ultrasound. Vascularity usually will be increased because of overworking of the gland, excessive iodine intake. And here the vascularity will be decreased because of thyroiditis, well-known fact. Here the vascularity will be highly variable. What is the treatment? Treatment-wise, here the gland is taking up excessive iodine, right? That's what the gland is doing. Obviously, you have to block that excessive iodine intake and block the excessive production of the thyroid hormones. Here in AAT type 1, it's excessive production. That's what happening. It's like a true hyperthyroidism. So you can use methimazole. Plus, you can use some drugs which are approved for shorter usage like perchlorate, sodium perchlorate, even though in the long run it's going to be very toxic. So you can use methimazole along with sodium perchlorate for a period of maybe 4 weeks. So once you achieve the euthyroid state, with these drugs, it's better to go for a radical cure, because amiodarone is some drug which is given in very difficult scenarios like a ventricular tachycardia treatment. So stopping amiodarone might result in death of the patient because of VT. So instead of doing all those things, you can go for a radical cure like radioactive iodine ablation or surgery, thyroidectomy, once the patient becomes euthyroid. So usually this thyroiditis will respond to high-dose corticosteroids. High-dose glucocorticoids like prednisolone, generally they respond, so that will be the treatment here. And still there will be a lot of confusion with AAT type 1 and AAT type 2. There are a lot of overlap cases also have been described where the findings will be considerably different and variable. So in those cases where you are having confusion, whether it's AAT type 1 or AAT type 2, or if you suspect an overlap condition, combine both. Combination if confusing picture. Clear. In hypothyroidism, obviously, you're going to give levothyroxine treatment. That's all. So it's very simple. Hypothyroidism is quite simple. You're going to supplement with levothyroxine. Replacement doses 1.6 microgram per kilogram per day. So final summary, amyloid-induced thyrotoxicosis type 1 due to Jod-Basedow effect, excessive iodine intake by a diseased gland due to Jod-Basedow effect, radioactive iodine uptake will be high, treatment with antithyroid drugs may be followed by a radical cure. Then amyloid-induced thyrotoxicosis type 2, usually due to thyroiditis, low radioactive iodine uptake, treatment with high-dose corticosteroids. Hypothyroidism is usually due to pre-existing autoimmune thyroid disease like Hashimoto's or some subacute lymphocytic thyroiditis. They will be usually anti-TPO positivity, and treatment will be with levothyroxine. So there is no need of any doing radioactive iodine uptake in these patients. So this is very important for exams. Clear, amiodarone can cause hyper, amiodarone can cause hypo, and there is a variety of mechanisms where amiodarone can induce thyroid disease. So with this, we'll sign off with the thyroid and we'll move on to the next topics on adrenal glands.